Hi everyone, thank you for having me today, and thank you for the lovely introduction. I'm going to be presenting some work using data from the TBIMS study. I don't have any disclosures to declare. So a quick background, as I'm sure everyone in the room is aware, TBI is a highly prevalent neurological condition with a high global burden of disease. Violence is the third most common cause of traumatic brain injury after falls and road traffic collisions. And TBI caused by violent or violent TBI is associated with poorer health and social outcomes. Prior research indicates a greater risk of violent TBI compared to non-violent TBI for various socio-demographic factors. However, the influence of psychiatric illness and substance misuse has not been comprehensively examined. In this study, we aim to quantify the strength of the relationship between psychiatric illness and substance misuse and the cause of injury in a sample of patients with moderate to severe TBI. So this is using the TBIMS models system database, the same data source that Professor Ponford mentioned earlier. This is the largest longitudinal study of moderate to severe TBI globally. Established in 1987, it recruits moderate to severe TBI patients from 16 sites across the US. You can see on the map here. There's been a lot of research completed using this data source. A review which searched the literature for, sorry if it's a bit hard to see, but for studies published between 2015 and 2020 found 74 peer-reviewed papers using this data source. And they looked at a range of outcomes. However, there wasn't any specifically looking at the cause of injury as the outcome of interest. Therefore, this study was a secondary analysis of this data set. Our sample were participants in the TBIMS dataset aged 16 to 54 and newly enrolled in the study between 2013 and 2023. Psychiatric illness prior to the TBI was assessed by self-reported utilization of psychiatric services. So this is whether they self-reported having ever been hospitalized for a psychiatric condition or sought mental health treatment or prior suicide attempt, and alcohol and drug use prior to TBI. And the outcome of interest was TBI injury mechanisms, which we dichotomized into violent injuries, which primarily were gunshot wounds and assault, and non-violent injury mechanisms. We used logistic regression to estimate the association between psychiatric illness and injury mechanisms. We used multiple imputation to address missing data and ran minimally adjusted models, which adjusted for age and sex, as well as fully adjusted models accounting for a range of socio-demographic factors. So the characteristics of the cohort, we had a sample of just over 5,000 patients with moderate to severe TBI. The mean age at injury was 33 years. It was predominantly a sample of white males, so just over 3/4 of the sample were men. Most were competitively employed at the time of injury or residing in urban areas. So psychiatric hospitalization, mental health treatment, prior suicide attempt, and illicit drug use were common in the sample. And in total, just under 12% of the sample sustained their TBI through violent mechanisms. And the majority of non-violent injuries were due to vehicular incidents or falls. So here are the results from the logistic regression. I've put a little star to show the significant confidence intervals. So having a prior psychiatric hospitalization, seeking mental health treatment, a prior suicide attempt, and illicit drug use were shown to have an increased odds of violent compared to non-violent traumatic brain injury mechanisms. And although accounting for socio-demographic factors attenuated the relationship, they were still statistically significant. But we did not find that varying levels of alcohol consumption were associated with either violent or non-violent injury mechanisms. Moving on to the strengths and limitations. To our knowledge, this is the first study to examine the relationship between measures of psychiatric illness and substance misuse and injury mechanisms for moderate to severe TBI in a sample of this size. The TBIMS data source is widely used for good reason. It's a great data set with, it's pretty representative of the US moderate to severe TBI population. One notable limitation is we weren't able to look at specific psychiatric conditions. It was just self-reported mental health treatment for any condition or psychiatric hospitalization. The sample includes mild TBI, which are most TBIs, but we're looking at the severe end of the spectrum, and the measures were self-reported. Yes. And then in summary, our main finding was that a history of psychiatric illness and illicit drug use increased the odds of violent TBI, even when adjusting for socio-demographic factors. This indicates that psychiatric vulnerability is differentially associated with violent injury mechanisms. And given the preventable nature of TBIs caused by violence, identifying psychiatric risk factors specific to violent injury mechanisms can enable the identification of high-risk individuals and the development of targeted prevention strategies. So thank you all for listening, and I want to thank my collaborators at Columbia for their help on this project.
Thank you. Thank you, Maya. There is one question. Yeah, go on, please. This mic here.
So thank you. That was a really interesting talk. So if I understand correctly, the dichotomization into violent and non-violent TBI, that was done retrospectively. So I was just wondering, obviously in some cases that's going to be very easy. So clearly a gunshot wound is a violent TBI, and someone, I don't know, falling over on an ice rink or something is non-violent. But presumably there's a big kind of grey area in the middle, and we know there's lots of barriers to, there's a lot of kind of hidden violence and barriers to reporting things like assaults and stuff. So someone who was recorded at the time as having fallen down the stairs, that may well have actually occurred in the setting of sort of domestic abuse and things like that. Was there any way with the kind of data set you had of trying to account for that, or how did you sort of handle that sort of grey area where you're not sure what actually happened?
Thank you for raising that. It's a good point. So TBIMS, with the data set, they just list what type of injury that they have assessed at the time of rehabilitation. So this is when they're in acute rehabilitation centers, so it's not necessarily immediately after the injury. We weren't really able to try and pass that out or have any more information. For example, one criticism is falls, TBIs recorded as falls, could also include whether someone's pushed, which would be then a violent TBI. So I do think it's like a very relevant limitation to look at. I would want to explore it more. We found it quite hard to look at injury mechanisms using these big, large data sets because it's hardly ever recorded, if at all. But thank you, it's a great point.
Thank you. Thank you, Mayor. Big applause. Thank you.